Welcome to the deep dive. Today we're really digging into your sources on something absolutely foundational, preconception health. We're looking at its crucial role in, well, fertility and how a pregnancy actually turns out. And the big idea here, the one we really want you to grasp, is pretty straightforward actually. Problems like infertility or issues with fetal development, they don't just pop up during pregnancy. They usually have roots before conception. So that periconceptional window and the health conditions men and women bring into it become incredibly important. We'll be covering things like weight, but also specific metabolic issues, even genetic factors.
Exactly. And our goal here is to make the why really clear for you. We're not just listing conditions. We want to explore the physiological mechanics behind them. We'll unpack how things like obesity, being underweight, high blood sugar, even, sensitivity to gluten can really interfere with the body's ability to conceive and carry a healthy pregnancy. Think of it as a step-by-step guide through the science.
Okay, great. Let's start unpacking that with something impacting so many people globally: weight status and its connection to fertility. Your sources note that certainly in the U.S., being overweight or obese is now way more common than being at a normal weight.
Right. And it's critical to get this. It's not just about the number on the scale. It's about what that weight means metabolically and, crucially, where the fat is located. We're looking at a double-edged sword here. Both having too much body fat and having too little can disrupt the basic processes needed for conception, like ovulation in women or sperm development in men.
Okay, so focusing on obesity first. Your sources point to a specific type of fat as the main problem. What is it, and what kind of chain reaction does it start?
Yeah, the real troublemaker is excess intra-abdominal fat. You might know it as visceral fat. This is that deep fat packed around your organs, and it's very metabolically active. Too much of it basically sets off a cascade of issues. Insulin resistance, which means your body doesn't respond well to insulin, leading to higher insulin levels overall, chronic low-grade inflammation, and oxidative stress. This whole cluster, well, that's what we often call metabolic syndrome.
Metabolic syndrome.
Yeah.
That term gets thrown around a lot. Can you define it in practical terms? What markers are we looking for?
Sure. Think of it less as one specific disease and more like a collection of red flags. You're considered to have it if you have 3 or more of these markers: a large waistline, high triglycerides in your blood, low levels of HDL, that's the good cholesterol, high blood pressure, or high fasting blood sugar. When you have this combination, it signals that your body's energy management is really out of whack, and that directly impacts reproductive hormones.
Okay, let's trace that impact. How does that high insulin level, driven by the abdominal fat, actually disrupt the female reproductive system?
It essentially hijacks the hormonal signaling. High blood insulin levels cause the liver to produce less sex hormone binding globulin, or SHBG.
SHBG.
Right,
Yeah.
SHBG. Think of it like a sponge that soaks up excess sex hormones, keeping them in check. When SHBG levels drop, you get more free, active testosterone circulating. In women, this excess testosterone, or androgen excess, messes with the communication between the brain and the ovaries. It disrupts the normal growth and release of eggs. The result? Often, it's an ovulation, meaning ovulation doesn't happen regularly or sometimes at all. Irregular or absent periods are a key sign.
That's a clear pathway for women. Does something similar happen in men, or is the mechanism different?
It's quite different, actually, and really interesting. In men, the fat tissue itself, especially that visceral fat, contains an enzyme called aromatase.
Aromatase.
And what aromatase does is convert testosterone, the main male hormone, into estradiol, which is a type of estrogen. So more body fat means more aromatase activity. The outcome is lower testosterone levels and higher estradiol levels. This hormonal imbalance then tells the pituitary gland to dial back on producing LH and FSH, which are the signals needed to stimulate sperm production.
So low T, high estrogen.
Yeah.
It basically slows down the sperm factory.
Exactly. And it gets worse. That high visceral fat also pumps out inflammatory signals and creates a lot of oxidative stress. This stress can directly damage the DNA within sperm, reducing both the quantity and the quality, how well they swim, independent of the hormone issues.
So the intervention seems pretty logical then. Address the underlying metabolic problems. Is weight loss the main strategy?
Absolutely. Weight loss is the first-line treatment. And often, you don't need dramatic changes to see results. Moderate exercise, think 150 minutes a week, like brisk walking combined with some weight loss, can significantly reduce or even fix the fertility issues. It works by lowering that oxidative stress and chronic inflammation. Now, in more severe cases, bariatric surgery might be considered, but, and this is critical, women need to wait at least a year after surgery before trying to conceive.
Why the wait?
because that rapid, significant weight loss can lead to some serious nutrient deficiencies. We're talking vitamins D, E, K, B12, folate, iron, zinc, copper, all crucial for fetal development. Getting pregnant too soon poses real risks.
Okay, let's use that idea of energy balance to flip to the other side. Underweight and negative energy balance. If too much fat messes things up, what happens when the body senses it's not getting enough energy?
This is where the body's survival instincts kick in. It's incredibly sensitive to energy availability. If it detects a significant calorie deficit or if body fat drops too low, reproduction basically gets put on the back burner. Survival comes first. Ovulation is particularly sensitive to this negative energy balance. It can lead to a condition called functional hypothalamic amenorrhea, or FHA.
FHA. Sounds
Yeah.
like the body just hits pause. How does that work physiologically?
It suppresses the release of gonadotropin-releasing hormone, GnRH, from the hypothalamus in the brain. GnRH is like the master switch for the whole reproductive system. Turn down GnRH and the whole cascade slows or stops. We see this often in situations like eating disorders, anorexia or bulimia, or even in female athletes in sports where extreme leanness is prized. Your sources mention a photo 3.1, illustrating this. Even an energy deficit of around 30% less than what the body needs can be enough to trigger FHA.
And the knock-on effects are significant. It prevents conception, obviously, but if someone underweight does manage to conceive,
The risks are higher. Being underweight increases the chances of preterm delivery and having a small for gestational age baby. There's also another consequence of FHA that suppressed GnRH leads to low estrogen levels, which isn't good for bone health. It decreases bone density and raises the risk of stress fractures.
so the treatment is.
Getting back into energy balance, restoring adequate calorie intake and, if needed, body fat levels. That's usually enough to reverse the reproductive shutdown and allow bone density to start improving again.
Okay, let's transition now. We've talked about energy balance, but what about chronic conditions where blood sugar control is the main problem? This links back to insulin resistance. Let's start with diabetes prior to pregnancy.
Yes, and with diabetes, we have to underscore the risk level. Poorly controlled blood sugar during that periconceptional period, those first critical couple of months after conception, maybe even before a woman knows she's pregnant, is profoundly teratogenic.
Teratogenic, meaning it can cause birth defects.
Exactly, serious ones. High blood glucose at that stage leads to a 2 to 3-fold increase in the risk of major congenital abnormalities. We're talking about problems with the development of the pelvis, the central nervous system, and especially the heart. This makes getting blood sugar under tight control before conception absolutely non-negotiable.
So what does management look like diet-wise?
It involves following a generally healthy eating pattern, but with some really key adjustments. You need to be quite aggressive about reducing added sugars and choosing foods with a low glycemic index, things that don't spike your blood sugar. And boosting fiber intake is crucial. The target mentioned is about 14 grams of fiber for every 1,000 calories you eat. What's encouraging is that lifestyle changes are really effective for prevention, too. Studies show that things like losing just 7% of body weight, if overweight, combined with 150 minutes of exercise per week, both cardio and strength training, can slash the risk of developing type 2 diabetes by about 50%.
Okay, let's tackle another common condition often linked to insulin resistance. Polycystic ovary syndrome, PCOS. It's described as a very common but often missed cause of infertility.
That's right. PCOS is complex, defined by a mix of features, signs of excess androgens, like testosterone, which can cause symptoms like unwanted hair growth, or acne polycystic ovaries visible on ultrasound, and ovulatory dysfunction. The infertility associated with PCOS is primarily because ovulation is irregular or absent. And crucially, as your sources note, maybe in Table 3.4, PCOS often overlaps significantly with metabolic syndrome. You see the excess abdominal fat, you see the insulin resistance, and you definitely see the resulting high levels of insulin in the blood. Hyperandrogenism is also a key feature.
So the nutritional approach seems like it would mirror the diabetes approach then, focus on improving insulin sensitivity.
Precisely. That's the primary goal. And here's where we see something quite remarkable, something we really need to emphasize. You don't necessarily need massive changes. Weight loss as small as just 5% of the starting body weight can be enough to restore regular menstrual cycles, lower those testosterone and insulin levels, and help ovulation get back on track.
Just 5%, that's quite encouraging.
It really is. It shows how sensitive the system can be. It's about shifting that metabolic balance just enough. But because PCOS is a chronic condition, the key is finding sustainable lifestyle changes, dietary tweaks, regular activity that someone can stick with long term. No crash diets.
Okay, let's pivot slightly to conditions that need really specialized diets, where the timing of that diet is absolutely critical. Let's start with phenylketonuria, or PKU.
PKU is an inherited metabolic disorder. People with PKU are born without or with very low levels of an enzyme needed to break down an amino acid called phenylalanine, which is found in protein-rich foods. So if they eat a normal diet, phenylalanine builds up in their blood to toxic levels.
And for a woman with PKU who becomes pregnant, the stakes are incredibly high if it's not managed.
Astronomical. It's called maternal PKU. High levels of phenylalanine in the mother's blood, especially during those first 8 weeks of pregnancy, act as a potent teratogen. The consequences for the fetus are devastating. High risk of microcephaly, a small head, severe intellectual disability. The risk is cited as 92% if untreated, seizures, and serious heart defects.
Wow, so the management must be incredibly strict. Can you describe what that involves, maybe referencing that food target diagram in the sources table 3.6?
It requires a lifelong, extremely specialized, low phenylalanine diet. It's incredibly rigorous. Imagine that target diagram. The absolute bullseye, the core of the diet, is a special medical formula. That's where they get their safe protein. Closer to the center, you have foods that are naturally low in phenylalanine, like most fruits, vegetables, specific low-protein breads, and pastas. These are allowed but have to be carefully measured and tracked. Then further out, essentially off-limits, are all high-protein foods: meat, poultry, fish, eggs, dairy, nuts, legumes, and even regular grains like wheat. Anything containing the artificial sweetener aspartame is also out, as it contains phenylalanine.
And that timing element you mentioned.
This is so vital. It's not something you can just start when you get a positive pregnancy test. It typically takes 4 to 6 months before conception for a woman with PKU to really master the diet, stick to it rigidly, and get her blood phenylalanine levels down into the safe range to protect the baby. Preconception counseling and planning are absolutely essential.
Okay, let's move to another condition involving diet and immunity. Celiac disease. How does an autoimmune reaction to food impact reproduction?
Celiac disease is an autoimmune disorder where eating gluten, specifically a protein fraction called gliadin found in wheat, rye, and barley, triggers an immune attack on the small intestine. Your sources likely have a figure 3.1 perhaps, showing this. Normally, the small intestine lining has these tiny finger-like projections called villi, which vastly increase the surface area for absorbing nutrients. In celiac disease, the inflammation causes these villi to flatten and become damaged.
Flattened villi. That sounds like it would wreck nutrient absorption.
It does, severely. This damage leads to malabsorption of a whole host of nutrients vital for reproduction. We're talking iron, folate, zinc, vitamin B12, and the fat-soluble vitamins A, D, E, and K. Your sources probably list these consequences, maybe in a table 3.7.
And how does that lack of nutrients or the inflammation itself translate to reproductive problems?
In men with undiagnosed or untreated celiac, it can lead to hypogonadism, low testosterone function, and delayed sexual development. In women, it's linked to amenorrhea, difficulty conceiving, subfertility, a higher risk of miscarriage, and problems with fetal growth during pregnancy.
Management is a gluten-free diet, right?
Yes, a strict, lifelong gluten-free diet is the only treatment. The good news is that once the disease is managed and the intestinal lining heals, reproductive function usually returns to normal. But sticking to that diet is challenging. Gluten can hide in many processed foods, sauces, medications, and the FDA's gluten-free label allows for up to 20 parts per million of gluten, so people need to be incredibly careful and vigilant.
Okay, for our last condition, let's shift towards managing symptoms.
Yeah.
Premenstrual syndrome, or PMS.
Right. PMS involves a pattern of symptoms, physical, emotional, behavioral, that consistently occur in the second half of the menstrual cycle, the luteal phase, and then resolve shortly after menstruation begins. It's important to distinguish PMS from its more severe cousin, premenstrual dysphoric disorder, PMDD. PMDD affects a smaller percentage, maybe around 5% of women, but the symptoms, especially the mood-related ones like severe irritability, anxiety, depression, and mood swings, are disabling.
Can you give some examples of the common symptoms listed, maybe from table 3.02 in the sources?
Sure. Common physical symptoms might include things like breast tenderness, abdominal bloating, headache, maybe some swelling. Psychologically, women might experience irritability, confusion, anxiety, feeling depressed, or having mood swings. There's a whole cluster of potential symptoms.
And what about nutritional support? Does diet or supplements play a role?
Well, there aren't really any definitive nutritional cures, unfortunately. The general advice focuses on maintaining a healthy overall dietary pattern, keeping a stable weight, and getting regular exercise, which seems to help some women. In terms of specific supplements, the evidence is suggestive, not conclusive, but two stand out as potentially helpful for certain symptoms. Calcium, usually around 500 milligrams a day, and vitamin B6, maybe up to 100 milligrams a day. Some women find these offer some relief. So if we were to boil down the major takeaways from this deep dive, it really comes back to preconception health being perhaps the most powerful predictor of a healthy pregnancy. Whether we were discussing weight management, controlling blood sugar and diabetes, managing hormones and PCOS, or adhering to very specific diets for PKU or celiac, the common thread is that individualized science-backed nutrition and lifestyle changes before pregnancy are key.
Right. So what this means for you, the listener, is that you have more agency than you might think. Often the most effective fertility treatment isn't some complex procedure. It's about optimizing your own metabolic health, ensuring your nutrient needs are met before you even consider conception. Getting your house in order first really builds that strong foundation. And that leads to a final thought. We talked about the incredible discipline needed for lifelong diets like those for PKU and celiac. Given how complex our food environment is today, hidden ingredients, eating out, what kind of support systems, beyond just individual willpower, do people need to successfully stick to such demanding regimens long-term, especially during that really critical and often stressful periconceptional time? Something to really chew on. Thank you for joining us for the deep dive. We'll see you next time.